Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager representing Gaslick Pharma, Switzerland. I extend a warm and gracious welcome to each of you for this webinar world tour. Today, we are privileged to host a distinguished speaker, Professor Daniele Cardaropoli, who is globally renowned for his fantastic work in periodontology. And frankly, he does not require any introduction. However, I will briefly introduce him. He has completed his degree in dentistry and his specialization in periodontology in the University of Torino, Italy. He's a president of Italian National Dentist Association section of Torino. He is a coordinator of the Health Information and Advertising Commission, and he's also a consultant doctor for Juventus Football Club. He's an international member of American Academy of Periodontology, and he's received many prestigious awards like Earl Robinson Periodontal Regeneration Award and Henry M. Goldman Award for Clinical Research of the Italian Society of Periodontology. He's an author for more than 50 articles published in peer-reviewed international journals, and he has written textbooks of periodontology, which are very, very famous for his excellent work. Currently, she's a scientific director of ProEd, that is Institute for Professional Education in Dentistry, Torino, Italy, and he's also a president of the Giuseppe Cardaropoli Foundation for Research and Care in Periodontology. He has his practice in Torino, Italy. So today, what Professor is going to tell us is, as we always, as clinicians, we have this dilemma of leaving the biomaterials for open healing. But he will show us the clinical evidence and its long-term success with open healing in alveolar-rich preservation procedure, and he's going to convince us for the open healing. So before I hand over to you, Professor Cardaropoli, few tips to make this webinar interesting and interactive for our live audience. I would ask you to please write down your questions in the question section, and we will address them after the webinar. And if you have any technical difficulty, also please write to us, and my colleague Artem Raskatov will guide you through. In addition, we will have one QR code which will be shown before we take the questions, which will allow us to send you more information about the topic that Professor will be talking about today. So keep your phones ready. So thank you very much, Professor, for being here, and the stage is all yours.
Dear friends, it is really a pleasure for me to be here with you with this online webinar, kindly hosted by Geisrich. Today, I will have the pleasure to share with you some very important knowledge that we have about alveolar ridge preservation. Alveolar ridge preservation is a well-established and solid technique that we use from many years. We have evidence that this technique is able to at least preserve something like 90-95% of the original volume of the ridge, and it is able to maintain the volume of the soft tissues as well. And maybe today we will try to focus on the soft tissue management when we apply the concept of alveolar ridge preservation. We know that when Professor Brannemark introduced the concept of oral osseointegration in the 60s, at the time, basically, we were focused on the use of parallel walls implants with a smooth or machine surface. And at that time, it was common to see these defects, the angular defects around the implant neck. And for many years, we have believed that these defects were usual and common and related to osseointegration, but today we know that this is more related to the establishment of the biological width and of the supracrestal complex. When we speak about immediate implants, we speak about something that started in the late 70s, and maybe this is one of the first papers that was published in literature focusing about immediate implant placement. So it means that we have a series of techniques that really changed the modern era of osseointegration. But when we speak about the post-extraction sockets, we should understand perfectly all the steps that are involved in the healing of the post-extraction site. So Professor Branemark suggested to wait at least 6 months between tooth extraction and implant placement in order to have a completely healed ridge. And then in the 70s, we started to see in the literature that it was also possible to place the implant right after tooth extraction. But in order to understand exactly the benefits of immediate implant placement, we have to see here 5 different clinical cases in which we have in the upper line 5 clinical images in which we can see some aesthetic failures related to immediate implant placement in the aesthetic area. And what it is interesting is to see that in the lower line of X-rays, each one is the X-ray of the picture that stays above. And looking at the interproximal bone level, all the 5 implants are quite perfect. The marginal bone level is stable. And so it means that today, in order to benefit from all the information that we can get from the technological tools that we have in the office, we have to combine 3-dimensional evaluation, both from the clinical point of view, looking at the soft tissues on the buccal area, and at the 3-dimensional evaluation of the bone tissues with combined images. So really, when we have a fresh extraction socket, there are a lot of questions that we have to answer before placing the definitive treatment plan. So we should be able to perfectly understand what kind of healing the fresh extraction socket will have and what kind of techniques we have to use in order to manage the post-extraction socket. To do this, we have to understand that the healing of the post-extraction socket is basically divided into 2 different concepts. One concept is the intra-alveolar process of healing. The other concept is the extra-alveolar process of healing. Let's have a look to these 2 different concepts. The intra-alveolar concept of healing is related to what will happen inside the socket. So inside the four walls that create the socket. To understand this, we go back in 2003 when my brother Giuseppe, together with Mauricio Araujo and Jan Linde, published this paper that is still today one of the most important paper in literature. So they did tooth extractions of several tooth extraction, and after tooth extraction, they were able to have histological evidence through biopsies taken after 1 day, 3 days, 7 days, 14 days, 30 days, that is 1 month, then 2 months, 3 months, 4 months, and 6 months after extraction. And in the histological evidence, they were able to show different tissues. And so we know that they were able to measure through histomorphometry the percentage of the presence of the coagulum, the granulation tissue, the provisional connective tissue matrix, the mineral bone, and the bone marrow. And so here we can see that after 1 day, basically, the post-extraction site is completely filled by the blood clot with blood clot stabilization. After 3 days, the fibrinolysis will start in order to have what we call the blood clot breakdown. After 7 days, the socket is filled with the provisional connective tissue matrix because the blood clot has been already resorbed, completely resorbed. In 2 weeks, we have the woven bone. The woven bone is the first stage of maturation of the bone tissue, moving from a non-mineralized tissue that is the osteoid to a mineralized tissue that is the woven bone. And then we have the lamellar bone. The lamellar bone is the more mature tissue of bone that is really a good step where we can place the implant. And then we see in 2 months, we have the formation of the cortical bridge, the bridge of bone, basically made of mineralized bone that is able to close the entrance of the post-extraction site. And then we start all the modeling and remodeling phases of the bone after 90 days, after 120 days, and up to 180 days. In order to understand the healing of what we call the extra-alveolar healing process, we have to move to another paper that was published by Mauricio Araujo 2 years later, in 2005. In this study, they did exactly the same design of the research with tooth extraction and then evaluation from the histological point of view after 1 week, 2 weeks, 4 weeks, and 8 weeks from extraction. But what is different between this article and the article that we have seen together before, the one published as a first name by my brother Giuseppe, is that in this histological evidence that we have with Mauricio Araujo, the histological cuts were rounded by 90 degrees. So now we have on one side, typically on the right side, the buccal side of the ridge, and on the left, the lingual side of the ridge. So we have always on the left the lingual and on the right the buccal. And we can see here, we have 4 different images at 1 week, 2 weeks, 4 weeks, 8 weeks from extraction. We have a yellow dotted line that is the one that links the most coronal peak of the lingual bony wall from week 1 to week 8. We can see that the yellow line is pretty stable. It means that there is not much resorption in the vertical dimension of the lingual bone wall after tooth extraction in 8 weeks. And then we have a blue dotted line, a light blue dotted line. Okay, this line, look, starting from week 1 and going to week 8, we can see that there is a huge decrease, a huge resorption in the vertical dimension of the buccal bone plate. And this resorption was measured around 2.3, 2.5 approximately in the vertical dimension. So it means that the lingual bone wall remains stable. The vertical dimension of the buccal bone does not remain stable. So we have a resorption in the buccal bone plate, as we can see in this morphine. Why we have this resorption? The resorption is related to the resorption of the bundle bone. What is the bundle bone? The bundle bone was described from the histological point of view in the paper published in 2003 by my brother Giuseppe together with Maurizio Araujo and Professor Jan Linde. The bundle bone is a thin layer of mineralized bone without medullary spaces. It is very, very, very thin, and it is 360 degrees all around the root surface. So it is like an envelope, okay, that covers and protects the root surface. And the bundle bone is in direct contact with the periodontal ligament fibers. We can see here the R-shaped fibers going inside into the bundle bone. On the other side of the periodontal ligament, usually what we have the root cementum. In this histological image, we do not have the root cementum because the tooth was extracted 24 hours before, so we have the blood clot. But in a standard situation, we have the root cementum, the periodontal ligament, and the bundle. So what is this structure? It is what we call the deep periodontium. So this is the supporting structure of the tooth. We have a periodontal ligament in the middle, and then two mineralized tissues. On one side, the root cementum. On the other side, the bundle bone. It means that the bundle bone does not belong to the proper alveolar ridge. Is not part of what we call alveolar ridge. It is a portion of the deep periodontium. If we remember when we were at the dental school studying on the periodontal books, we learned that the deep periodontium is made by three structures: cementum, periodontal ligament, and bone. Which kind of bone? Which bone? This one, the bundle bone. So, since the bundle bone belongs to the periodontal structure, the deep what we call the deep periodontium, it means that the bundle bone will be resorbed. So once the tooth will be extracted, the periodontal ligament will be resorbed through an inflammatory reaction in a few weeks. And then after the resorption of the periodontal ligament, also the bundle bone will be resorbed. There is no way, no possibility to maintain the bundle bone or to preserve the bundle bone. In 2003, Lars Prof made a clinical study on humans, on patients, in order to understand the amount of resorption of the alveolar ridge following spontaneous healing. And so we see in the study by Lars Schropp that in 1 year, 12 months following tooth extraction, we have a 50% reduction of the ridge width, starting from a value of around 12 millimeters in width, the horizontal dimension from buccal to lingual. After 1 year, we have 6.1, 50% of reduction. With spontaneous healing, we will lose a lot of bone volume. And basically, around two-thirds of this resorption will be made in the first 3 months of healing. Going back in 2012, then we had maybe the first or one of the first systematic reviews about the treatment of the extraction socket. And so from this systematic review, we know that with the spontaneous healing, in average, we have an horizontal reduction of the ridge width of 3.8 millimeters. With spontaneous healing, in average, we have a vertical reduction in the ridge height of 1.24 millimeters. 3.8 millimeters of bone volume reduction in the horizontal dimension is a lot, because 3.8 is like the original diameter of the Branmark implant, very, very, very close, maybe 0.5 millimeters of difference is nothing. 0.05 millimeters is nothing. So it means that with spontaneous healing, we will lose the diameter of bone corresponding to the diameter of an implant with spontaneous healing. And in the vertical dimension, in 6 months of spontaneous healing, in average, we lose 1.24 millimeters. And also this is a number that will have an impact. So here we can better understand the healing of the post-extraction site. So we started with our root here on the left. The tooth is extracted, minimally invasive extraction, what we call a traumatic extraction. And then we have the socket, we will have the bleeding and the blood clot stabilization. After the blood clot stabilization, the blood clot will be destroyed, we will have the blood clot breakdown, and then new tissue formation with the provisional connective tissue matrix first, the woven bone second, and the lamellar bone third. So, in the central portion of the ridge, we will have bone healing, a very good bone healing. But unfortunately, what will happen in the central portion of the ridge is very different from what will happen in the other surfaces of the ridge, both on the buccal, on the lingual, and in the vertical dimension. Because we can understand that the ridge volume following spontaneous healing will experience a huge amount of remodeling, both in the vertical and in the horizontal dimension. Now we can see here a clinical case, a lower molar. We did a flapless extraction, minimally invasive, and look, after 4 months, despite the minimal invasiveness, despite that the interseptal bone was maintained, in 4 months we had a lot of bone remodeling. look at the difference between the buccal bone surface before and after. The difference also in the lingual area before and after. So we have maybe 50% of remodeling in the horizontal damage. So the question is, can we avoid this bone resorption? Can we do something to avoid this? We know from literature that immediate implant placement is not able to maintain the volume of the ridge, because the implant, what we call dental implant, is just a titanium fixture that cannot change the healing pattern of human beings. So it means that it's not a good option to place an immediate implant if we aim to preserve the post-extraction site volume. We place immediate implants for sure. We know how to do it. We have also consensus on this, but we know that we do not place immediate implant because we want to maintain the volume of the ridge. We place immediate implant for other reasons. Basically, maybe the most important, one of the most important, is that if we are able to deliver an immediate restoration together with the immediate placement, we will maintain the original architecture of the soft tissues. And then, of course, we will shorten the treatment times if we go immediate. According to literature, there is another option that works very well in order to place the implant. This option is what we call alveolar ridge preservation. Alveolar ridge preservation is a technique in which we can graft the post-extraction socket. And thanks to the grafting, we will keep the volume because the bone substitute will be able to compensate the marginal bone remodeling following the extraction of the tooth. The alveolar ridge preservation is made of two different steps in the surgical time. First one is to fill the socket with a bone substitute. The second one is to protect the bone substitute in some way. So regarding grafting of the socket, we know that we can use several biomaterials, or also potentially we can use autogenous bone. Autogenous bone chips inserted in a fresh extraction socket didn't show the possibility to really maintain the original bone, but we have a lot of bone resorption, so the volume is not maintained. Then if we speak about alloplastic allograft material, the evidence in terms of numbers that we have in literature does not show that the allografts or alloplasts are able to maintain the volume with predictability. So according to literature, it seems that xenografts perform much better than allograft and alloplast. This is really, really important to know. And regarding what we call the open healing, well, it means that we can protect the bone graft without the need of opening a flap and advance a flap in order to get the primary closure of the flap on the top of the bone graft. Because we know that if we open a flap, according to Nobuto and co-workers, we will have a lot of bone resorption because of the osteoclastic activity. And we also know that if we advance a flap to cover for primary attention closure, we will lose the mucogingival junction. So for all these reasons, is really interesting to see and to understand if we have other option than the primary attention closure through soft tissue advancement. So what we know is that the combination of the bone graft together with a membrane, we published this randomized controlled clinical trial in 2012. Well, this combination using bovine bone mineral blended with 10% of collagen fibers, this is our, I would say, really preferred biomaterial. The Bio-Oss collagen is exactly the biomaterial that my brother Giuseppe started to study more than 20 years ago in Gothenburg University. Is the biomaterial that they used in the first studies where they created the bone diff. And so this combination, 90% of bovine bone granules blended with 10% of collagen fibers, is really the best biomaterial that maybe we can use in post-extraction sites. And then we have to protect the biomaterial. It is like a symbiosis. So the use of a membrane, a collagen membrane, will protect the biomaterial from the outside, from bacteria, from soft tissues, from whatever. At the same time, the graft, the biomaterial that we have placed into the socket, will support the membrane. Otherwise, the membrane will collapse. If we use a membrane without a bone graft, the membrane will collapse. And so we can see here an upper premolar, flapless extraction, grafting with Bio-Oss collagen, and then a piece of Bio-Gide porcine derived membrane, resorbable membrane, was trimmed and placed on the top of the Bio-Oss, and then just fixed, not directly sutured, but just in order to keep the membrane stable. We can see here we used an horizontal cross mattress. Look, after 4 weeks. So we left the membrane intentionally exposed. The collagen membrane is not like the standard PTFE membrane that if is exposed in the oral cavity will get infection and then we will lose bone. No, the collagen matrix will not get infection, but will create a layer. It will be like a scaffold where the soft tissues will heal on top of it. And from the histological point of view, we know that if we have a keratinized tissue on one side, in this case on the buccal, and we have a keratinized tissue also on the other side, on the lingual, what kind of keratinized tissue we will have in the middle? There is no other possibilities than new keratinized tissue. There is no possibility from the histological point of view that we will have alveolar mucosa in that end. So only keratinized tissue, it means that we will create a lot of new keratinized tissue. And I will show you several cases. So the concept is to create a scaffold made of, I would say, friendly biomaterials like the collagen membrane, and then we will see together in few slides the collagen matrix. And this biomaterial, this membrane, is able to guide the soft tissue cells to cover the membrane itself and deliver new tissue. What kind of tissue? Keratinized tissue. Because if we have keratinized tissue on one side, keratinized tissue on the other side, in the middle, no other possibility than that new keratinized tissue. We have histological evidence of this kind of healing, both into the bone area and in the soft tissue area. And so in the soft tissue area, we have the epithelium and the connective tissue. And between the epithelium and the connective tissue, we can see here the lamina propria. There is no inflammation in these tissues. And this tissue will create the soft tissue profile around the implant because it's what we call the supracrestal complex. Supracrestal complex is this one. And then if we go inside the bone, we can see bovine bone mineral together with the woven bone and osteoid tissue at the 400 magnification. Look, we have a bovine bone mineral granule completely surrounded to 170 degrees by woven bone. And again, at 400 magnification, a lot of woven bone with cells. So the osteoblast will deliver the mineralized fraction of the bone tissue, so the osteoid will be transformed in new bone tissue. If we do not use the alveolar ridge concept and we wait for spontaneous healing, look here. The huge amount of remodeling with spontaneous healing in 4 months, we lose 35-40% of the original volume of the ridge. And so what we have here? We have in 2012 the data coming from the measurements of the randomized controlled clinical trial. And we know that with this approach, we can maintain approximately the 93% of the original volume of the ridge in the horizontal dimension. With spontaneous healing, in average, we lose 33, 34, 35% of the original volume of the ridge. The vertical dimension with ridge preservation, only 0.46 millimeter of reduction. With spontaneous healing, 1.54. It means 3 times more than with the ridge preservation. And the histological evidence shows that with ridge preservation, we have 26% of new bone, 18% of residual graft, very good, and 44% of mineralized fraction. In the control side, with spontaneous healing, we have 43% of mineralized fraction. Not much difference from the histomorphometric point of view. So on the left, we have an example of ridge preservation. It works perfect. On the right, an example of spontaneous healing. We lose a lot of volume. With ridge preservation, the dimension reduction is only 1.04 millimeters. With spontaneous healing, 4.48 millimeters. There are 3.5 millimeters in average as difference. According to the volume, with ridge preservation, we will lose only 7% of the original volume. With spontaneous healing, 33-35% of the original volume. And it is easy to understand the impact and the role played by ridge preservation in this drawing. So here we have an upper premolar with resorption of the root, endodontic failure, and we can see together how it works. The ridge preservation is very easy procedure. We just have to learn the concept, to become familiar with this surgical approach. So after the debridement of the socket, we start to graft. This is the Bio-Oss collagen. This is the Cardaropoli bone plugger that in this specific situation will help a lot. We need to create a good compact graft, I would say, into the socket. And then this is a piece of a Bio-Gide membrane that has been trimmed exactly to the size of the socket. It is placed under the sulcus, no flap elevation, under the sulcus, and then it is stabilized with a cross horizontal matrix suture. And then some drops of hyaluronic acid. Today we have some good experience with a new gel that is rich in hyaluronic acid and polynucleotides, the reagent fast gel that will help a lot in this kind of clinical situation. So going back to the intraoral images of the case that we have seen in the video, after tooth extraction, we debride the socket, we graft with Bio-Oss collagen, we protect with Bio-Gide, and you see the Bio-Gide is completely exposed, intentionally and completely exposed. This is the healing after 2 weeks, no infection. The risk of infection is very, very, very low. I would not say zero because in medicine, in dentistry, 0 and 100 does not exist, but it's very close to zero. And then in 4 weeks, the carotinase tissue is completely healed. And look, the concept of ridge preservation, we can see here. The buccal bone has been resorbed, but since we grafted into the socket, the horizontal dimension is maintained. So we will not preserve the socket. We will maintain the ridge volume. The buccal bone usually will be resorbed anyway. But then, since we have grafted the socket, we are able to maintain the bone. So we can place the implant. In this case, a flapless implant with very good primary stability. Look at the implant in place, quite perfect. And the concept of ridge preservation is this one, to compensate. Alveolar ridge preservation is able to compensate the marginal bone remodeling. And so we have the buccal bone plate here is very thin. This is made probably only by the bundle bone. And then we have the graft into the socket. In 4 months, the bundle bone is being resorbed, look, but the graft has been transformed in new bone, where we can place the implant, and the implant will remain stable. We have data coming from literature that the marginal bone level and the buccal bone thickness will remain stable 1 year after implant placement, because they are similar to the native bone. There is a relationship with the buccal bone thickness, we know from the literature, and this relationship is not affecting the healing of the socket if we use ridge preservation. If we go with spontaneous healing, yes, the thickness of the buccal bone plate will affect the healing of the post-extraction site, will be a spontaneous healing, but will not affect the healing of the post-extraction site via ridge preservation. And this is a randomized review and the meta-analysis, a systematic review with meta-analysis showing that not all the biomaterials are the same and not all the techniques to protect the biomaterials are the same. So we know that xenografts usually performs better than alloplast and allografts, as already mentioned, because we are able to maintain the volume, to keep the volume stable with slow resorption xenograft. And then we know that it's much better to use a membrane. If we use a membrane, so we protect the bone graft, avoiding any advancement of the mucogingival flap. If we protect the graft with a membrane, we have better outcomes, not only in terms of keratinized tissue, but also in terms of bone. volume. And today we know that we can treat cases like this. This is a challenging case because we have a large periapical lesion apical to the apex of the root, and the periapical lesion is in contact with the buccal bone plate. So in this situation, there is no indication to go immediate. We have to go stage. And according to the post-extraction site clinical classification, we know that we have class 1 when the socket is intact and we can place the implant, class 2 when the socket is intact but we cannot place the implant because of anatomical structure, class 3 when the buccal bone is no more intact but not so deep, the bone resorption, and then class 4 when the periapical lesion and the presence of periodontal inflammation or any other kind of inflammation will create a severely compromised site. This is a class 4. So for that patient, we are in class 2, and I will show you how we treat it today because we don't use the collagen matrix anymore because we have the possibility to use a matrix. No more the membrane, but the matrix. We use the collagen matrix. My preference is for the mucograft. The mucograft seal is a collagen matrix, 8 millimeters round. The diameter is 8 millimeters. So, and the thickness is 3 millimeters. We can see here. And it is easy to suture the mucograft matrix to the surrounding tissues. It is this technique of suturing going with the 6 single interrupted sutures. This technique is very, very, very well accepted by the patient. And the matrix is left opened. Look here. It is opened, openly. So the matrix, what is really important is that we can use the characteristics of the collagen fiber. So we can stretch the fibers in order to have a perfect sealing all around the entrance of the socket with the soft tissues. I don't want to see any void space, any empty space between the matrix and the soft tissues, because below the matrix we have the graft, we have the Bio-Oss collagen. I don't want to have any risk of bacteria going down and create a risk of infection for the bone graft. This is very important. But look what will happen. Look at the knots of the sutures, day 0. After 7 days, they run on the top of the soft tissues. The healing from peripheral area to the central portion. This is baby gingiva. This yellow tissue is not pus, it's the fibrin layer on the top of the matrix. And then we have the Bio-Oss collagen. After 10 days, look this tissue. This is gingiva. The keratinized tissue moves towards the center of the ridge. 2 weeks, baby gingiva, pink. 3 weeks, almost done. This is open healing. We have a lot of advantages, and from the mucogingival point of view, if I have to speak as a periodontist, it's something unbelievable because we increase the amount of keratinized tissue. And then we have the benefit of the alveolar ridge preservation because we maintain the bone, both in the vertical, horizontal dimension. Even if the buccal bone plate is thin, it works. And we maintain also the vertical dimension in posterior area, avoiding the pneumatization of the side. It works very well, and we know from literature that in case of ridge preservation, we have only 4% possibility to add additional guided bone regeneration procedure the day of implant placement. with spontaneous healing. The 60% of the times we have to go with the bone augmentation, with the guided bone augmentation the day of implant placement. It works in the posterior area. It works also in the anterior aesthetic area. This is an upper central incisor with external root resorption, ridge preservation. So we graft with Bio-Oss collagen and we protect with the mucogat seal collagen matrix. Left intentionally exposed, we have the 6 single sutures. The X-ray at the end of the surgery looks after 2 weeks. How beautiful these tissues are. This is biology, because the collagen matrix is like a scaffold. We have a second attention closure with a lot of keratinized tissue moving on the top of the matrix. 6 weeks, 4 months, and then we are ready. X-ray, we open the flap, we collected our biopsy, we see a lot of new bone. Look at the quality of the bone that we are here. We can place the implant knowing that we have only 0.11 millimeters of bone resorption after bone age crest level. So in average, we know that we will maintain 94% of the original volume, even if the buccal bone plate is very thin. So the ridge preservation will work also with the buccal bone plate that in average is very, very, very thin. And we have a new bone of something like 45% between 4 and 6 months from ridge preservation technique. So we can conclude saying that alveolar ridge preservation in extraction sites can compensate for 93% of the ridge width, and it is effective independently from the bone thickness. The buccal bone plate thickness at baseline, only 4% of implants will need additional bone regeneration procedure. Implants will have some outcome as implants inserted in native bone. And the open healing concept is able to increase the amount of keratinized tissue that we will have the day of implant placement. So from the biological point of view, is a very good opportunity. And we have read a lot of cases like this, where there is no indication for immediate implant placement. The matrix is exposed, and in 2 weeks, 4 weeks, completely hidden. Look the amount of keratinized tissue that we have here. The volume is maintained in the horizontal, vertical dimension. Implant placement in maybe 10 minutes, a lot of stability. We can provide our crown and everything is stable after 1 year. And this is the last case, a huge periapical infection. We remove the root, we debride the socket, we graft with our Bio-Oss collagen, we protect with collagen. At that time, many years ago, it was a collagen membrane. The collagen matrix was not available yet. This is after 2 weeks. Then we waited. After 4 months, we opened the flap, we placed the implant. Again, a lot of histological evidence. Look at the quality of the bone. Perfect. We placed the implant, 72 ISQ. After 6 weeks, we were ready with a provisional ISQ value was 77, the crown. And look, I had the possibility to see the patient after 15 years. She moved back again in Torino because many years ago she moved from Torino. Now it's back. He came to the office because of the cavity on the first molar. But look, this is the implant that we placed 15 years before with the ridge preservation. It's perfect. The implant is perfect, not in the natural teeth. The premolar and the molar, they have some issues to fix. The X-ray after 15 years, everything is perfect. The marginal bone level remains stable. So we know that alveolar ridge preservation is a solid technique that we can use in our patient. It works very well, and we have a lot of literature supporting this technique and this approach, dear colleagues. If you want to be involved in a beautiful program that we are creating in Torino, in my hometown, we will be more than happy to welcome you in Torino in April 18, 19, 20 of April. We will have a master class in soft tissue management and bone augmentation around implants. We will speak about the need of keratinized tissue, the increase of demand of keratinized tissue. But today we know that when we speak about soft tissues, we speak about the three-dimensional volume, not only the band of a keratinized tissue, but also the thickness of the keratinized tissue. That is the most important concept in order to maintain the stability of the bone. And we will speak also about bone tissue, the techniques and the biomaterials that we have in order to increase the volume in the vertical dimensions, so horizontal and vertical bone augmentation. We'll speak about the management of the soft tissues, also the lingual flap, the malorhyoid muscles, the tension, and we will have hands-on, we will have live surgeries, we will have a slide presentation and a beautiful time, food and wine in Torino. If you need more information, we go and you can send an email. This is my email address, and I can reply to you and give you more information. So, dear friends, it's been a great pleasure to share this evidence to you, and you can find in this slide or the social media contact in order to be in touch with myself. Thank you.